I'm Harlan Krumholz, professor of medicine and a cardiologist at Yale University, and I'm joined today by Bob Harrington from the Duke Clinical Research Institute and soon to be head of medicine at Stanford University at the Stanford School of Medicine. Welcome, Bob.
Thanks, Harlan.
Today we're going to talk about a topic that's arisen at the American College of Cardiology meeting with a presentation of the ASCERT study, a comparative effectiveness study based on the merging of two registries, the ACC NCDR registry and the STS bypass surgery registry, and a linkage with the Centers for Medicare and Medicaid Services database to allow long-term follow-up of mortality. And this study demonstrated that the one-year outcomes between bypass surgery and PCI were very similar, but by 4 years bypass surgery, the patients who had undergone bypass surgery had better survival. The issue that it raises is whether or not an observational study like this, these patients weren't enrolled in any study, it was retrospective, it was a merger of these two databases, whether this kind of approach can provide information, generate knowledge that can truly inform clinical decision making, and whether or not the investments in these types of studies, when we're going to compare different strategies, are ones that should be good going forward, or whether or not we should think about other designs. Bob, this is a really interesting study that was presented at the meeting.
And you know, Harlan, this is sort of the backdrop of the DCRI. I mean, the DCRI grew out of the Duke Databank for Cardiovascular Diseases, and what was one of the original contributions, it was trying to understand bypass surgery versus medical therapy, right, and then PCI bypass in medical therapy. So at Duke, we have a lot of experience with this. And at a place like Duke, where we have a lot of experience with this, we would say it is not the best method to understand medical interventions. It's informative in the sense that you can learn, perhaps you can establish your hypothesis, but if you really want to know about how to apply a medical intervention to a population, then ultimately at the patient level, you have to do a randomized clinical trial.
So we're pushing for efficient study designs, and these data existed. We were able to pull together data, look long term. I'm stymied
in a very elegant way.
Yeah, in real world practice, yep. We often talk about the trials as being kind of specialized centers or specialized patients. Real world practice, I'm stymied by how we're going to proceed, because we have to overcome the problem that the trials are often expensive. They take a long time to do. By the time they come out, they're out of date sometimes. Here's something that was as close as possible to recent practice as you could get with 4 years of follow-up. Where's this going to lead us?
But here's the problem, right? Because the problem of confounding is never adjusted for in its entirety. There's a level of granularity in the data that you probably just don't have, that you want to be able to adjust for. So when you, at the end of the day, observational studies in some ways, it's a little bit for everybody. If it's the answer you like, well, it was adjusted well and it looks good. If it's the answer you don't like, you say, well, what about all those unmeasured confounders that we weren't able to control for? So for me, yeah, they are an efficient way to do a study, but a year and a half, 2 years later, however long it took to do the work, you're still left with uncertainty as to what is the answer. I think the answer is much more, in an era of comparative effectiveness, what we need to be figuring out is how to do trials more efficiently. I mean, how many PCIs are done in this country a year?
Yeah.
A million plus?
Yeah.
How many CABGs? Hundreds of thousands plus? Yeah. We can't randomize 10,000 patients and answer the question? And the answer is we can't. I mean, you may know we're involved with this interesting study that's led by Judy Hockman called ischemia. We're trying to answer the question, if you have stable ischemic heart disease and high-risk functional study, a lot of ischemia, randomize you to a cath strategy or an optimal medical therapy strategy. The cath patients also get optimal medical therapy, and then revascularize if you have appropriate anatomy. It's going to take us 8 years to answer the question.
Yeah, because the enrollment's hard. I want to make sure the people listening do know that observational studies have particular roles and for questions for which they're
absolutely
ideally attuned. If you want to understand about clinical practice, if you want to understand about patient trajectory or risk stratification, I mean, these are real world populations that we can use. We're talking today about
intervention.
Comparing interventions.
Right.
Do you think there's something, though, particular about this study? I mean, for one thing, by going retrospective, they didn't even know if all the PCI patients were eligible for bypass surgery, would have even possibly considered it. And in addition, they didn't have information about functional status. Now, by the way, I want to say the people did a wonderful job with the data that they had. The elegant statistical approaches, Bill Weintraub, who led it, it's a triumph of a study for what they had. But the question is given the challenges of these data, I mean, is there something about this that makes it difficult? Are there places you think we could do observational studies with comparative effectiveness?
Part of the issue here, Harlan, is the magnitude of the treatment difference that you're looking for. And the epidemiologists have taught us a long time ago that when you're looking for big effects, an observational study might be enough. You might be able to understand if something is 2, 3, 4 times better than something else. You may be able to pick it up with the appropriate sample size and with the appropriate statistical techniques. And as you said, in the ASCERT group, it was very well done. But we're not talking about those kind of treatment effects in most of what we do. What are we looking for? We're looking for modest incremental differences. And the data is just insufficient in an observational study to do that. And I don't care how big your sample size is. It's not the size of the sample. It's going to be all, what did you measure? And as you pointed out, there's some pretty key determinants of what you're going to have that were not included. Your functional status, whether or not you're actually eligible for both procedures.
Yeah, I'm thinking more, at least for me, that you've got to follow the principles. Actually, Ralph Horowitz wrote about this years ago, where you at least need the group that's eligible for both therapies. And if we do it prospectively, we at least can do a better job of making sure we're collecting information about the things that we think might be affecting selection, especially the non-clinical factors. That is, factors around functioning health status, like you're saying, that we can do a better job. But if the differences are going to be very small, it might be hard to detect.
I mean, we've been here, you and I, at the ACC all weekend. In any trial that is deemed a success, what is the treatment difference? Relative differences of anywhere from 10 to 25%. Absolute differences of what? 1 to 3%, 1 to 4%.
Yeah, we're at that point.
We're at that point where we're looking for incremental gains, and incremental gains are not going to be detected.
So we're talking about globally, but just getting down to ASCERT. So are you going to do anything differently in practice as a result of this study? I saw some headlines that say CABG edges PCI at 4 years. I saw others that really were much less definitive in the headlines that took from the journal. I thought the journal article was very balanced in its approach. Any difference in your clinical care?
I'm not going to do anything differently. I think that if I go back and look at the guidelines, the revascularization guidelines that came out, the appropriate use criteria that came out, I think they've largely gotten it right. High-risk anatomy, poor LV function, 2 things we've known for many, many years. Surgery seems to be the winner. You want to calculate the syntax score and use that as a discriminating point, that the higher your syntax score, the more likely you are to benefit from CABG.
Although recent studies show that in the lab, people aren't very good at calculating.
They're not very good at calculating. But the other, I've asked this question to a lot of people this week when they say, we got to make these models, these decision tools easier for people to use. And I say, well, why? Why can't we make the math as complicated as we need to, but just don't show that to the clinicians?
The interface will be easy.
The interface should be easy, but the math doesn't have to be easy. It can be as complicated as needed.
So this is going to, I think, follow us, and people are going to be seeing this played out in articles and in discussions. We need to compare strategies. We need a lot more information for clinical practice. What's going to be the right design? How are we going to do it? It's not going to go away.
No, it's not going to go away, and I think it's really what I think we should be thinking about is how do we do trials more efficiently. We can't keep doing the trials that we're doing right now. It is unsustainable. And as you know from looking at your work on the guidelines, the vast majority of things we're giving people recommendations on are not formulated on a high degree of evidence.
So we need to increase the evidence. I think Bob's a trialist, so I'll tell you that he's firmly on the trial side. I will say I think there are many places where it's just not going to be feasible for us to do trials. We'll need to bring in information from observational studies, but we're going to continue to be dogged by this issue in the design about whether or not we've eliminated the confounding.
Yeah, I would say it a little differently. I would say I'm a clinical scientist, and I want to use the method that's most appropriate to the question you're trying to answer. And if I look at my own work over the years, a lot of what I've done is observational. But when I want to ask a question of A versus B, it has to be a trial.
Very fair, very fair. Thanks, Bob.
Thanks, Harlan.